Thank you. This thing is supposed to, can you hear me okay back there? Do that, maybe helps. Thank you. It's good to be here. It's a great conference and a good day, and a lot of friends and folks that I work with out in the audience. What I'm going to give you is a presentation that a few of you that were at the Legislative Healthcare Coverage Commission a week or two ago saw. Jennifer Vermeer gave it, and she does a much better job than I do. But she's on vacation today, and I said, no, don't come in. I'll cover this one. But if you want to have her come to your group and do the presentation again in a much more depth, we can make Jennifer available. But basically, in my 10 or 15 minutes, I just want to touch a little bit on, some of you already heard, I'll try to go over that quickly, the implications for Medicaid with the Health Reform Act or the ACA or PPACA or whatever you call it. As we noted earlier, there are the development of exchanges for individuals to purchase insurance. I think Susan Voss, her staff has kind of the lead on that. There's some meeting we're having tomorrow between DHS and the Insurance Commissioner's Office and others. Department of Health's involved to work on how that exchange is going to work in Iowa and start to move that forward. So that's one way that insurance is going to be purchased, as you know. There are the tax subsidies that play into the exchange. For Medicaid, what we're going to see is an expansion to individuals at 133% of poverty. And I think in terms of the public discussion of this, most of you probably understand this, but for the public discussion, most people aren't quite aware that Medicaid doesn't cover all poor people. There's the impression that it's insurance coverage for poor people, and it really isn't. It's coverage for disabled people, it's coverage for children in certain poverty classes, but it doesn't cover those single adults and childless couples. That's where the main expansion is going to come. If I push this button, it's supposed to do something. That's what I'm reading off of. And that's the top line. So one takeaway today, I think, for you is to keep reminding yourself that Medicaid is not now basically health insurance coverage for poor people. It is for certain groups, subgroups, that are below certain poverty levels, and there are about 10 or 12 different poverty level numbers within various Medicaid programs. Everyone has a different percentage level that they're at. So right now we have 25 different groups. We're hoping through this that we can narrow the scope down a little bit. So the single adults, childless couples are going to be the big group that are going to come in. Right now we cover some of those folks through the Iowa Care program, the Iowa Cares plan. About 35,000 people take advantage of that program. There's a lot more people out there who could. Iowa Cares is a 1115 waiver under Medicaid, which allows us to use federal and state Medicaid dollars to cover people who would not otherwise have coverage, right now up to 200% of the poverty level. We are in the process of adopting new rules to expand Iowa Cares this summer. Those rules were just filed a week or two ago. They'll be published, I think, in the bulletin that comes out next week, if I remember right, to the expansion. We're expanding that to go beyond the current coverage. Right now, if you want health care coverage through Iowa Cares and you meet the guidelines, you go to University of Iowa hospitals or you go to Broadlands if you live in Polk County. That makes it not very convenient for an awful lot of the state. So we're expanding that, and when the new rules come out and we implement that starting this fall, we're going to start with some of the federally qualified health care centers, clinics around the state, to have them be primary care providers and medical homes in their parts of the state. I think we're starting with Sioux City and probably Waterloo, and then we hope over every 3 or 4 months to add another 1 or 2 of the FQHCs as funds are available and as we see how this program is going to work. So that'll be something coming out new to expand Iowa Cares and in a medical home kind of model. So for us at Medicaid, it's sort of the start of trying to implement a medical home model in Iowa with a certain population. The University of Iowa hospitals will also be a medical home for people in their catchment area, and so will Broadlands. So we'll be working towards that end. The Health Care Act removes all of these various restrictions and just goes to a pure 133% level. That's going to capture somewhere between 80 and 100,000 additional Iowans that'll be eligible in the Medicaid program starting in 2014. That's about a 20%, 25% increase in our population for Medicaid. It'll make us, we're already probably the third largest healthcare insurance company, if you will, in Iowa. It'll make us even bigger. There are new income standards and guidelines. There are new procedures for accessing the program. We're still waiting for a lot of guidance from CMS, so we have a lot of questions we don't have answers to. And there are some options for states to implement certain things earlier. I don't know that we're going to do that. We'll have discussions with the legislature about that. We'll look at the options as to what we're going to be able to do. But ultimately, it all comes in, as you know, in 2014. One implication of this so far is that starting in 2014, we're going to have two different Medicaid populations. We're going to have the new eligible group, which will be funded with 100% federal funds, and we'll have the old eligible group, if you will, or the other eligibles, which will be funded under the current state-federal mix, which means we're going to have two eligibility systems. And all of that, what that entails. We are trying to encourage Congress to maybe think about shifting away from that over time, to go to one. There are reasons, obviously, from a budget standpoint that the federal government wants to know the difference. I understand that, but from a software standpoint, eligibility standpoint, and the complexity standpoint, how long do we continue to track the new eligibles versus the old eligibles? And you would have, even though you're coming into the system in 2015, you would have been eligible under the old system. So you're an old eligible, you're not a new eligible, as I understand it. Whereas if you wouldn't have been eligible before, but you are now, then you're a new eligible. So that is going to add some complexity and difficulty as we go forward. Not that it can't be managed, but it is going to add some complexity and difficulty. So that's a concern. The funding does start to decrease as we get into the out years in terms of the federal share for the new eligibles. We're going to be expanding Medicaid coverage to foster children to age 26. Now, that's a good thing. Now we have a lot of foster children that age out of the foster system, and we drop them, basically. They're out of foster care, they're out. We are starting to do some things in terms of education to help continue services beyond age 18. We have some extension programs for foster kids. This will help with the healthcare side. The CHIP program continues to 2019, and there's a maintenance of effort piece that I don't think very many people are focused on. States cannot reduce eligibility or restrict eligibility below what they are doing now, beginning in 2014 or until 2014. So you can't drop your levels down in order to pick up more newly eligibles starting in 2014 and sort of, if you will, game the federal system to do that. States aren't going to be able to do that. You've heard a little bit of discussion about the modified adjusted gross income. That's a whole different way of determining eligibility. We didn't put the chart in of our eligibility determination system, but we have the software, something called the Iowa Automated Benefits Calculator. It's a software. And when you put that on a chart, there's like 100 different pieces that go into that in determining a person's eligibility for different programs. That software is all going to have to change. So that's going to be a major undertaking for us. And in the software world, in my experience in government, the changes that are going to be, just some changes in the system, take 2 years. If they say 2 years, plan on 3. There's a lot of lead time to get it right, and a lot of lead time then in implementing it and testing it and making sure it's working. So 2014 is going to come pretty quickly. We are going to look at a lot of things we think we can do to streamline eligibility, to try to line up more eligibility requirements for various programs to get them more on the same track instead of having all of these different kinds of things. That can help. Those are some things we can do at the same time. That can help. Modified adjusted gross income for our eligibility purposes, and this is probably more in the weeds than most of you want to know. It's a whole new thing. Right now for Medicaid, we look at household income. For most of our programs, we look at household income. We don't look at taxable income or modified adjusted gross income. So it's a different approach. And what we don't know yet is it your modified adjusted gross income that we pull off your tax return that you filed for 2009. Right now, the household income is a monthly test. We want your household income this month that you're applying. And then you reapply, or that's checked periodically. So that's going to be a different mix, and again, the federal government hasn't provided all the answers. But there's some different kinds of things we're doing here. We're going to look at everything we can, as I said, to streamline procedures. And this is down to 4 minutes and 50 seconds. So I'm either talking long or Jennifer's presentation is longer than I expected it to be. Let me get to the key parts here. Let me skip that one. Yeah, transitioning. What we really are looking at doing over the next couple of years is trying to transition Iowa Cares into the new eligibles, if you will. As we expand and transition Iowa Cares to having more providers, more places around the state, and demonstrating the medical home model in that setting, we want to use that as our test and our implementation of how we're going to roll out the Medicaid expansion model in the future. So that's really the key part to us. I've already mentioned the numbers. The legislature is going to have to talk about, we're going to have to talk about what the plan is going to be for these new eligibles. States have some choices. States have to establish a benchmark plan, that's the second bullet point up there. Now, for administrative purposes, as a bureaucrat, it'd be nice if it was the same as every other plan, as a Medicaid plan, but it's not a separate carve-out or a separate kind of benefits. And that would be easier administratively and also fairer and work a lot better in the system, rather than something like Iowa Cares is now, which is a limited package. So there'll have to be discussion there of that. As I mentioned earlier, there's a lot of software and system changes to go through. Right now, our system software is a 30-year-old system, basically, on the mainframe that's been layered onto every few years. That's a huge undertaking, and we'll come to the legislature this year with some estimates of what it's going to take to get there. Now, fortunately, under the Act, depending upon how we do it, we think the federal funds will pay for about 90% of the software changes. But making the changes, making some of these initial determinations about what you're going to determine for eligibility, what your base package is going to be, all those decisions had to be made that go then to the programmers to program the software to get you there, is going to be a real challenge to keep it moving. What we're waiting for is the first item. We just need lots of federal guidance. Some of you have been involved in meetings nationally. Our folks have been to lots of meetings. There's going to be a lot more. But we need a lot of these questions answered to get to the point where you can start making decisions. We expect there'll be new fraud and integrity efforts. There's a lot of discussion going on right now within DHS about program integrity, not just in Medicaid, but in a lot of areas. With this new eligibility system, we also want to build in additional anti-fraud and eligibility fraud kinds of efforts where we can. And let me get to, I think I touched on the unknowns already. I covered all of those. Costs. Back up to that one. Fiscal impact. With expanded population, there will be some additional cost to the state. No question of that. I don't think anybody knows yet how much. There are also going to be some enhanced federal funds in terms of the higher share for the eligible population, and there are going to be some decreased costs in some areas. We should be able to shift significant populations that are now in some of these other programs that are above 133% of poverty. We should be able to shift significant numbers of those folks to the exchange subsidized kind of program, and that could save us some funds. There are some long-term care options we think that'll save us some funds. And we think preliminarily there's some interesting options, not in the traditional sense that we might think of it, but in the mental health care system. As we look at how Iowa funds mental health care with a combination of county, state, and federal money, and mental health being more of a function that's going to be provided for this population in Medicaid now, we can move to funding more mental health and behavioral health services out of Medicaid funds, and less out of whether it's state dollars or county property tax dollars. So we think there's some opportunities there to actually save some state and/or local money. And we're working on those and intend to have that discussion with some of the legislators here in the audience over the next few months. So with that, I'm going to sit down and turn it over to Susan, or to the speaker. Okay, thank you.